Tumor is not situated at mid-depth. It's usually beneficial to deliver a higher dose from the field where the tumor is shallower, hence weighting the beam. So, what does that mean? It works better if we have a parallel opposed pair. Okay, so you have two fields. One coming in from there, and one coming in from there. The tumor is here. So it says that if it's not centered at mid-depth, beneficial to deliver a higher dose from the field where the tumor is shallower. So that would be written AP, PA 1 to 2, for example. So what does that mean?
One side is going to be double the amount of the other.
Yeah. So which one would be which?
Based on that,
No, well, based on that, but based on this.
higher dose. So the higher dose would be PA.
So how would you go about finding out how much to give each field? I've made it really easy. It's never as easy as this. So you've got 1 to 2, so you're right, twice as much for the PA than the AP. Does that make sense to everybody? Okay. So, if I want to give 300 centigrade daily to the tumor, how much to each field?
100 AP, 200 PA.
So how did you do that?
Oh, yeah.
1 to 2.
So
200 is
it's
twice.
I made it too easy,
Yeah,
basically.
yeah.
So what you do is you have 300 centigrade, you know that it's 2 to 1. So what you have to do officially, when it's really weird, is, so that's 3. You divide 300 or your total dose into 3 by 3 and multiply by 2. It's never as easy as that, but that's what weighting is. So you can, it's easier to see in an APPA, but you can do it for 4 fields. So if I said that, okay, I want 3 fields, I want 4 fields. One goes here, one goes here. So if I say that this one is 30%, this one is 50%, and this one is 20%, both of these are 20%. It gets a little more complicated, right?
That's way more than 100.
But, okay, make it 10% then. So then you would use the same thing, you'd add them all up, divide, and multiply. But with IMRT these days, you don't have to do that very much. But this is all conformal. And some people still use conformal. That's the basis of weighting. So wedge fields. Used to alter the dose distribution. So this can come in with physical wedges or dynamic wedges. It's used to alter the distribution. The wedge angle needed depends on the hinge angle. The hinge angle is the angle separating the two central axes. Okay. So the wedge angle, go back to here. So let's do this. So to find out that's a azimuth curve with a wedge. So to find the wedge angle, whoops, sorry, my straight line is not good here. So you draw a line which is through the central axis. You draw a line here. This is the angle. And we'll explain that a little more as we get further in. This is just giving you an overview. So the wedge angle is 180 minus half the hinge angle, and we'll get, as I say, we'll get back to that later. So, recommended by the ICRU. What is the ICRU? First one is international.
It's right there though.
Where?
Commission on Radiation.
Oh, so it is. Shoot. Okay, International Commission on Radiation Units, that's the ICRU. Okay. So the GTV is the gross tumor volume, the gross palpable extent and location of the malignant growth. That's the smallest. The GTV is smallest. The CTV, the clinical target volume, is a tissue volume that contains the GTV and the subclinical microscopic malignant disease. So in other words, it's the GTV plus anything that the doc thinks might be malignant. Any microscopic area. That would be the GTV. Anything that he thinks needs to be treated. And that's the CT, which is bigger than the GTV. And the biggest area is the planned target volume, or the PTV, which contains the tumor and adjacent tissues and an area which is called a margin, which allows what? What's the margin for?
Should be clear tissue, like clean, no.
Movement or,
Patient movement,
or inaccuracy of no verbs today, no.
okay. So patient movement, internal movement, so remember the prostate, like it moves a little bit. And also well, I won't say inaccurate,
You're
but
one word that covers that, what we call it. Essentially like a margin of error.
yeah, it is a margin of error.
But there is one word.
So, yeah. So it's basically inconsistency of positioning.
Is it always, it's always healthy tissue then, right? It's not,
Yeah, it
it's not
usually is.
considered in the.
No, it's not. It is a margin for error. So it's considered normal tissue that we have to include just in case somebody messes up, or the patient wiggles, or the prostate hiccups somewhere along the line. Okay. So dose normalization. Okay, so let's see what else we need to do on. Something else I was gonna add to that. Oh, yeah. So, how big is the margin for error usually? Do we have a size?
I feel like everything is 2 cm.
For 3D conformal, it's usually about 2 cm. For palliation and 3D conformal, it's usually between 1 centimeter and 1.5 centimeters to 2 cm, depending on the physician. For IMRT, it's usually less than 1 centimeter. For stereotactic treatments, there is none. There is no margin. So your CTV and your PTV are usually the same because there is no margin for error. And I know it says always larger than GTV, but, oh yeah, it is always larger than GTV. It's not always larger than CTV. In that particular case, the CTV for stereotactic is exactly the same as the PTV because there is no margin for error. That's why we have to have the patients totally immobilized. Right? Questions before we go on?
ITV, I'm seeing that in several places. What is the I?
The ITV is an
Intended?
it is gee, I can't remember what it is now.
I wrote down internal target volume, so that's all I have.
Internal target, yeah.
So where
ITV
in that
ITV is usually between GTV and CTV. So it would be the same as the GTV, it would be the tissue volume that contains the CTV and without usually the subclinical. So it's a little bit bigger than the GTV, but smaller than the CTV. Sometimes people will ignore the CTV and put an ITV in there. So contours. So you've got the patient on the CT, or you're going to prepare to do a plan or you need to do a contour on this patient before it goes to planning. The CT is unavailable. So you need to do a contour. Now the easiest way to do a contour is to do a CT, right? We don't have the CT. It's unavailable. The engineers have it in bits all over the floor. So how do we do a contour on this patient? How do we do a contour on this patient without CT?
Should I use the term coat hanger again?
No. Nobody would know what that meant. You have to be clinically correct.
I was just seeing if you were paying attention.
That I remember. So how would you do a contour on a patient? Wish I had filled some of this stuff that I used to use, but never thought about it. So how can you use, what can you use to do a contour on a patient?
Well, what is that wire called? I don't know the terminology.
Solar wire.
That you.
Solar wire.
Solar, like,
Solder,
oh.
as in solder.
Solder, okay.
It's the same thing. Or a piece of wide wire. There used to be ones that were made for that had the wire encased in plastic, green plastic that you could mold around the patient. It's easier to do, but I guess I've stopped using them now. So anyway, you can use a piece of heavy wire. So you would get a piece of graph paper and you would put on the graph paper, you would put anterior, posterior, right and left. Right? Then you would get this long piece of wire, have a patient lie down. First of all, you want to know where you're doing your contour. We'll call it a pelvis, it's easier. You put your patient on the bed. I'm not gonna lie here, otherwise. So you get the patient on the bed, you get this piece of wire, and you would pull it down over the contour of your patient. You get a pen of some kind. You would get the midline and you put a mark on the wire and put M/L, which is midline, AP. You would put a mark on for the right, mark on for the left, and then you would very carefully take it off, bring it over to your graph paper, put it down. Then what would you do? Get a pencil, very carefully. So you need 3 hands to do this, but you have one hand, one finger here, one finger here, and you draw inside, being careful not to move the wire. And then you would label this midline, right and left, PA, AP, and the patient's name. And that would go to your dosimetrist, who would take that contour, call it all sorts of names. And they usually scanned it in. So you'd have this contour. So you could also use, what else did we discuss? You'd also use something else to do the contour.
That plaster.
else. What was it called? Plaster of Paris, yeah. It's still used. We used to do masks with plaster of Paris. And then we'd mold plastic around it, so we'd have a mask. You'd have plastic. Anyway, what you do is you get a long strip of that plaster of Paris, make it wet, put it around your patient, again, mark off, let it dry, put marks on it, take it off again very slowly, put it on your paper, do the same thing, hand it to the dosimetrist. Of course, now these days, everybody has got CT, so we don't have to worry about that. But it's important you know, just in case, why we do this. So plaster of Paris, multiple level contours, changing separation along the proposed treatment area. So from CTs, patients are on a flat table insert, okay. So has anybody ever had a CT done? For anything? No? Has anybody ever seen a CT
I had a CT in my
outside
mouth.
of the treatment area? In a hospital, a normal diagnostic CT? No? Okay. The beds are curved. So instead of having a flat bed like we have, the beds are curved like this. So if we're going to be doing a CT on a hospital CT, sometimes some departments still don't have CTs of their own. So they have to use the hospital CTs to do planning. Can we use those CTs? Why?
Bed.
Too much can change between the time you do
No.
that CT and then the inconsistency with the system that you're gonna be integrating it with.
You do the CT this morning, send over to planning.
The bed is curved, and in treatment it's flat.
Pardon?
If the bed is curved in CT and the treatment is flat, then it's going to be different.
Yes, exactly. That's what I was aiming for. So if you're doing something like that, you need to make sure that the hospital CT or whatever imaging center or whatever you're using has a flat top for their CT, and they do make them. So they have a flat top for their CT so that you can put them in the correct position. Because it's no good trying to fit a mask and do a CT if the bed's curved, because it isn't going to work, right? So, oh, sorry. Patients are on a flat table insert. CT custom table for, yeah. So we have to make sure that anything that is done in an outside CT, whether it's in the same hospital but it's a diagnostic CT, or in an imaging center across the street, we have to go over there and make sure that they're doing everything that we want them to do. For example, if we need a vac log done, we have to take the vac log. If we need a mask made, we have to take a mask over, so that we know that everything is being done correctly. Because radiography positioning and our radiation therapy positioning is entirely different. If we ask them to do, how do you treat a pelvis? Where are the feet? Are they like this, or like this, or like this, or where are they?
Straight,
They're straight. Everybody agree with that?
unless they can't do
Feet are
that.
straight. And if they can't do it, then they're slightly like this, right? Make them comfortable. If you ask a diagnostic tech to do a pelvis, to do an x-ray of the pelvis, they're gonna put the feet like this. They're gonna do the feet like this. Because that way, it's the way the hips are placed. That's the technique that normally they would use. So, something as simple as that, we would have to make sure that they do. Field placement is crucial. We have to make sure that if they're doing a CT, it's done to our specific instructions. Much as they'd hate to do it, if we're doing a therapy CT, they have to follow what we want. Even if they've been doing CTs for the last 20 years, we still have to do it our way. So, target volume and dose limiting normal structure. So this is localization. This is what we're aiming to do. Treat the tumor, miss everything else. That's our theory, right? Don't give 100% of the dose to the tumor and nothing to the rest of the tissues. Is that something that we can do? Is that something that is doable? Treat 100% of the tissue of the treatment volume and give nothing to everything else in the area? Of course not. You can't do that. Radiation doesn't allow you to do that. There's certain tissues that you have to treat through in order to get to the tumor site. So, target volume and dose limiting normal structures. So we'll go back, we'll do a CT. We're doing prostate. What are the organs at risk for prostate?
Bladder,
Rectum, bladder?
seminal vesicles.
Not necessarily. Small bowel, somewhat, yeah. Seminal vesicles, they treat a lot of the time. That's why I'm saying they're not office organs at risk. Sometimes when we're treating prostate, we also treat seminal vesicles.
I said, but if you're not treating them.
If you're not
then they
treating them,
are.
yeah, they are organs at risk. But normally, if you're treating a prostate, you're also treating the seminal vesicles. Okay, so we have to make sure that we're limiting the dose to the bladder and to the rectum. Those are the two primary ones, right? How do we go about doing that? So the rectum, how do we go about trying to treat as little as possible of the rectum? Anything?
Full bladder,
Who?
full bladder.
We're not doing bladder yet, we're doing rectum first. Okay, what are the things that you can do to limit the dose to the rectum?
It doesn't-
Ignore the bladder for the moment. Sorry?
Oh, that
Yeah,
Christina was
doesn't
talking.
that kind of help though? A full bladder kind of pushes.
Well,
it
no, we can do that later, but
bifold.
we're honing in on the rectum. Is there anything that we can do ignoring the bladder. Anything we can do to limit the dose to the rectum.
Empty rectum,
Pardon?
empty rectum.
Empty rectum. Okay. What about a full rectum?
I was gonna say balloon.
Balloon.
Space or
Yeah. So why do we bother putting these guys through getting a balloon every day?
Because they wanna charge them money.
True. But is there another thing that they want to do?
put a space between the
Separate.
rectum and the other organs that you're trying
Yeah.
to avoid.
Yeah, okay. So that's basically why they do it. And the fact that they can charge them more money, or they can charge the insurance company more money.
Cause I keep hearing, you don't need balloons, they just do it. I'm like, then why are they doing it?
Yeah, yeah. The full rectum helps too. And, okay, let's do the bladder. Full bladder. What constitutes a full bladder?
Well, apparently where I'm at now, it's 50% full or more.
50% or more is, but well, I guess it just depends on physician's orders, because some of them want 70% or more.
80 is ideal.
It is ideal, okay. So who drives that? Who says 80% is a full bladder, or 50% is a full bladder? Who's telling us that?
Physician.
The physicians. So it's up to them. If they want 50% full, okay, we'll give them 50% full, or more, right? How can you tell? How can the patient tell if his or her bladder, well, because it's a prostate, we'll call it his bladder is 50% full, or 80% full, or heaven forbid, 90% full?
The amount of liquids that they're told to drink.
Yeah, you can do that. How much are they supposed to drink? And this probably varies from place to place too. How much are these patients told to drink?
2 cups, which is 16 ounces at PTI.
Say again?
At PTI, it's 2 cups, which is 16
2 cups.
ounces.
So 2 cups, as in cup.
Yeah, they're 8-ounce cups.
So they're 8-ounce cups. So 16 ounces. Does that fill a bladder?
It fills my husband's bladder. At the 30-minute mark, he's like, I have to pee. And I'm
Yeah.
like, no, they're about to come get you. Just wait. He's like, I've got to go. I've got to go right now.
My clothes peg, yeah. Sorry. Yeah. Guys are much easier to tell them to hold it than the ladies are. So anyway, so 16 ounces.
On that note.
Hold it.
Where's David?
Okay, so what if you give them 2 cups, 16 ounces, and he comes in on the first day and it's not even 50% full?
Well, we had one the other day, they made him just lay on the table for 10 minutes,
I would send them back to the meeting.
and then we checked on
They need to start drinking it earlier or drink more.
Most of the time you would start them drinking it earlier. Because normally 2 cups, 2 8-ounce cups are enough to fill most people's bladders. But it depends on how long it takes them to fill up. Because it takes a fair amount of time between here and here.
I also wonder if their level of dehydration plays a role in it too, because if you're really dehydrated and the rest of your body needs fluids, how much of it is diverted to the rest of your
Yeah.
tissues before it goes to the
So
bladder?
you have to make sure that they're well hydrated. But, this is the problem when you start a patient to begin with. Your new patient comes in and he's told to take 2 8-ounce cups of water or a 16-ounce cup of water. And he does that. And you bring him into the room, you do your cone beam CT, and there's not even 50%. So you take him out of the room, put him back in the waiting room and say, here, drink some more, drink some more. And the patient gradually gets used to how much it takes to fill his bladder. What we used to do was we gave the patients cups that were about that size, the size that Stephen has. And we tell them that this is, you need to drink two of those. Yeah. One when they're having breakfast in the morning. If it's first thing, they're treating them first thing in the morning. And then fill it up and drink another one on their way to the clinic. And then we'll treat them as soon as they came in. That works well unless we're running behind. Then everybody is making a dash for the bathroom. So it's a sort of give and take. You have to make sure no two bladders are the same, unfortunately. It would be nice if you could say, okay, 16 ounces fills everybody's bladder. It doesn't. It may overfill somebody's bladder. Some of these little old guys that are 84, and if they take one cup, then they need to pee. It's all very weird. So what other dose limiting structures can we talk about? Okay, let's continue with this. Errors, a tumor miss or an inadvertent irradiation of organs or radiosensitive organs. Somebody can't spell. Why might there be a tumor miss? Why might there be a tumor miss?
They
Go back
move.
to the prostate. What would make us miss the tumor? Anything?
Patient motion. Internal motion.
Patient, which one?
Either one.
Okay, let's do, internal motion, we know the prostate moves. That's why we use IGRT. We do IGRT right before we treat them so that the prostate has no time to move anymore. If we didn't use IGRT, we'd have to use a bigger field so that we're sure, even if the tumor moves a little bit, we're still getting into the treatment area. So what about patient movement? We're still treating the pelvis. What kind of movement might cause us to have a tumor miss? If the patient does this,
Yeah.
or he lifts his belly up, does this, gets himself comfortable. If you see it, what do?
Stop.
Stop. Then what?
Go in and start over.
Go in and reset the patient up. If you see that type of movement, it has to be a lot for us to see it. So if you see it, or if the patient coughs, or sort of does this or something, and we're treating the pelvis and because whatever it wants to do in his hands, you need to go in and check. you need to reset the positioning. It doesn't happen too much in the pelvis because it would be different in the chest where if the patient's hands are up and he starts moving his arms around. That might move the chest. Or if he coughs or sneezes or something like that, then that could move him. Pelvis, once you get him positioned, it's pretty normal for them to lie still. Unless, of course, they need to pee or something like that. No, raising their arms, that. Right? Okay. So that would cause a tumor miss. And if we miss the tumor, what do we hit?
That doesn't need to be here.
Exactly. So we have all these organs at risk. We do not want to treat an organ at risk. But if we miss the tumor, we are going to hit an organ at risk.
I heard the dosimetrists calling organs at risk PRVs.
PRVs.
Something about risk volume or something. Because he was like, because we were treating a liver and he's like, I don't know why this is listed on here as liver PRV. We're trying to treat the liver, so just ignore that. And I was like, thinking in my head, what the heck is PRV? And so one of the other therapists was like, what is that? Because they didn't even know what it was.
Yeah. So
And it's something risk volume, but he said that's what they call organs at risk.
okay. So it must be the software that they use. That's what they. What are they using for planning software?
I mean, it's like the mosaic and all that.
Oh, it's Mosaic. Okay, yeah. Because it could be just their
Well, there's multiple
definition.
dosimeters, so like somebody else could have put it in there like that, and because he was like, I don't know why it's like that, like he didn't do it.
Oh, okay.
So
Yeah.
I don't know.
Well, yeah. So lasers. What do we use lasers for?
Align external anatomy.
Alignment. Okay. Alignment of what?
Their body.
Their bodies, okay. So what do we align the lasers to?
Their marks.
Their marks or their tattoos, whatever. Their marks, okay. Whether it's tattoos or just paint marks. The tattoos don't move, paint marks do. Right? Who's not using tattoos? Anybody not using tattoos?
Just you, yeah.
So,
I've never seen a tattoo done.
you've never seen a tattoo done?
Yeah.
I prefer the marks, to be honest.
Why?
They always
It's-
ask.
You can always see them, they're easier to show up. You don't get patients where it's like, where's your tattoo at? I don't see
And
it.
then you gotta turn the lights on.
Seeing it easier. Like, I've had to pull out my phone flashlight when we were setting up the progress this week.
That's
because
why
you
you,
could not see
that's
it.
why you need a little flashlight.
Well, I like the,
Yeah, I always just,
actuals that have
so
the
like with the
flashlight.
Electros, they
Yeah.
don't.
The other
But we
thing
just
that
turn
you
the
can
lights on.
use, guys, just for a notification for you, is alcohol swabs. If you get an alcohol swab and you swab the tissue or swab the skin around where you think the tattoo is, it'll show up.
It lights up, yeah.
It'll
Candace
show
did
up.
that right towards the end.
Yeah.
That little trick.
Yeah.
He goes, what? How did
Never
you do
It
that?
just like,
It just
makes it shiny almost.
Yeah,
Like,
it
easier to see.
the moisture of the alcohol makes the tattoo pop.
It's temporary,
You
so
rub
if
it
it
directly
dries, you
over
won't
it
see
or
it.
around it?
On it, just where
Like,
you
where do you
want
think
it.
it
Over it,
Okay.
if you think you know where the tattoo
In the
is,
general area.
in the general area, just swab it across and it'll pop.
And some of those women, like the older women who have the loose skin up here, if they have a tattoo up here, a lot of times this is why I said that they don't always use the AP tattoo at Gainesville, because the skin moves.
Yeah.
It's very,
Yeah.
just loose.
Yeah,
Or
well,
even the bigger women.
that's a reasonable idea, but then of course you could put a tattoo in the central
I have
axis
seen them
down.
for free
Yeah,
for those people.
yeah. Why not use tattoos? Why is the use of tattoos better than skin marks?
Because it won't wash off.
Won't wash off, yeah?
Sometimes they
What
just
else?
fade.
Hmm?
Sometimes they do just fade.
They fade.
We lose them completely sometimes.
So, Stephen, why do you think marks are better than tattoos?
I feel like it's more accurate too.
Why?
As far as, at least from where I'm at now in Gainesville, so they use the marks that they had from CT set up, and then we'll actually move the parameters to full feet, or image, whatever modality we're doing. But I like the marks because, or at least UFPTI, when we use the marks, we also do the treatment marks. So we liven this, we set them up to CT marks, move them to treatment marks, and then go do the imaging. And it's,
Yeah.
Faster.
it
So-
seems quicker, and it's also less adjusting, in my opinion, less.
Okay, so I'm gonna play devil's advocate here, just so that you know. If you have just skin marks, and I know that some of the departments have different colored marks for CTs and treatment and everything else, we'll just ignore that part for the moment. If you're only using skin marks and have no tattoos, the patient has refused, we're not doing tattoos, so you have skin marks. What happens if they lose them?
It becomes a pain in the butt.
Picture references.
So re-CT them. What happens if, okay, this is Friday, and Mrs. Smith is gonna lose her, you know she's gonna lose her marks by Monday. So you redo them. Are you redoing them in exactly the same place as they were before?
Well, before you take the sticker off, you put where the lines are, so that way,
Mm-hmm.
when you take the sticker off, then
But I
it is
see
in
what
the
you're
same
saying, if you
spot.
did that throughout 30 fractions every week, I mean, it could move.
Especially
Yeah,
if it smudges
exactly.
a little bit.
So it might only move a millimeter or a couple millimeters, but everybody's eyes are slightly different. So if you have a mark here and it's fading and you know it's fading and it's not gonna last till Monday, so you remark the mark. And then on Wednesday, oh, it's fading again, and somebody else remarks the mark. And although that you put a little mark here and put a little mark here, and then you take the cover off, you're still moving it a little bit. That's the problem with marks. And I've done both. I've worked with tattoos and no tattoos. Because I've worked in the department where the doctors refused to put tattoos on patients. And it is a bind.
One of the confusing things that can happen with tattoos though is if they have been treated before, that's gotten me 2 or 3 times. You'll see them at Gainesville, sometimes they'll have multiple sets. So
Yeah.
you have to
Oh,
read the
tattoos.
special instructions
Yeah.
to see
So
which
that
one you're lining up
That
to.
brings up another point. You should never, if you can possibly help it, have more than one set of tattoos. So if a patient, for example, or a patient who has the spinal med, thoracic spine med, he may have had prostate treatment before. And he can't lie on his belly, so he's lying on his back. And you are doing a CT for the spine med. And it's up here, right? So you're doing thoracic spine, so center's about here somewhere. Now, you could easily use the tattoos for the prostate. And then put a big note saying, prostate tattoos used for setup only, treatment, positioning, move 8 centimeters superior. And that saves you from having 2 sets of tattoos. Does that make sense? Yeah. We had a gentleman in when I worked in California, and he was a new patient to us, and the doc says he's a prostate, so just do normal prostate CT. So I said, okay, come along and we'll get him all organized. We've got his back clot done and everything. And I'm positioning him, and I saw tattoos, and they were right here. And I said to the gentleman, have you had treatment before, sir? No, this is your first time in radiation therapy? And he was about 80 something. So I'm thinking, this is weird. This is very weird. So I got on a call to the doctor and I said, Dr. Canna, you need to come along and see this gentleman. Why? I said, because he already has a set of tattoos. Where? On his pelvis. You sure? Yes. Okay. So off she comes. And she says, where? Show me. Here, here. Oh, yeah. And she says, have you had treatment before, sir? No. Have you had treatment? No. She's already asked me that. Why are you asking me that? So it turned out that the gentleman had been CT before and had marks put on, and then he declined treatment. So he already had his set of tattoos done, but he never had treatment. All very weird. So, anywho, if you can use the older set of tattoos, albeit you have to make sure that everybody knows what you're doing. This is where the setup instructions come in. As I said, use pelvic tattoos for setup only, for positioning only, treatment, move 8 centimeters superior.
So in CT, when they give them the tattoos, is it possible they can hit them, like, do they have different colored tattoo marks? Like, do they only hit them with that dark black blue line?
You can get different colors, but that would end up the same.
They say that something always goes wrong. There's
Yeah.
always a reason that the different colors don't work. So
Yeah.
I'm suggesting the white for the darker skin.
Yeah.
Yeah, that's what I was.
Patients, there's gonna have some really dark patients, you
Like a
cannot.
very light.
We used to, you wanna know what we used in London? We had a lot of very dark West Indian patients, really, really dark guys. And we were looking around for something to use because they certainly didn't make white tattoos at that point. This is the early 70s. And we thought, what can we do? So we went to the pharmacy and we said, what can we do to do something that will go underneath the skin but won't cause any problems? So we had this little bunch of us trying to figure out what we could use. Anybody care to guess what we ended up using? It sounds very weird.
White out.
We used whiteout
Under the skin?
under the skin. And it caused no problems whatsoever,
Unless you're allergic to whiteout.
unless you're allergic to whiteout.
What is
Yeah.
even in it?
But, well, that's what.
Yeah, how do we
found
know it didn't
out.
cause
And,
problems?
As I say, this is 1970s, so a
So we're
lot
gonna know
has
now.
changed since then.
Right.
But we had no problems with it actually, and it worked very, very well for our very dark guys, for our very dark patients. And we had a lot of them. But, so anyway, so the lasers. We got talking, that's right, because depending on what you use, you either set up to the tattoos and move to the treatment area, or move to the treatment marks, or we set up to the treatment marks. That's all very well if the lasers are accurate. They should be checked daily, the lasers. How much leeway do we have for the lasers? What kind of error are we allowed for the lasers? How do you check your lasers are on? Yeah, how do you check them though? Physically, how do you check the lasers? How do you do the QA on the lasers?
Like a little cube.
A little cube, okay? And what do you do with the little cube?
Line it up.
So you have crosses on the cube, and you bring it up and you check the lasers. Okay. What happens if they're out? Call somebody. Call somebody. Yeah. How much of a leeway are you given?
1 point.
Usually it's 1 millimeter. Occasionally you'll get 2. But most physicists prefer 1. So if they're out, then you call the physicist. Because when you think about it, your whole positioning, your whole setup, your whole treatment depends on the accuracy of the linac, of the lasers, right? This is another reason why I don't like marks. How thick are the marks?
Like 3 millimeters.
Yeah,
It depends on who's doing them. When they
Yeah.
fresh come from CT, they're
They're so
typically
thin.
nice, but they
Yeah.
don't say that.
exactly. So you want your lasers where? In the center of the cross. Now, the lasers, how thick is the pen? Thick.
The marker pen,
The marker pens. What do you use?
they use Sharpies.
Sharpies, yeah. Now, the Sharpie, you can get fine Sharpies that are really nice until they get old and then they spread out a little bit. So if you're using a normal Sharpie, they're about this thick, yeah, a couple of millimeters thick at least. So you're trying to put a laser which has to be within 1 millimeter. We're presuming it is accurate if it's within 1 millimeter. You're putting that in the center of this wide cross. Now my center might be slightly different from your center. And your center, they all might be slightly different. You look at it and say, I think we need to move it up, yeah, okay, I'm good. And you look at it, that's off, you can spend hours doing that, so. That's why I prefer tattoos for positioning.
So a lot of times I'll see like they'll do a tattoo in CT, but they don't, like, they'll put marks on for setting up to make it faster, like after the shifts and everything.
Mm-hmm.
So that's what
Yeah, so the tattoos are the CT marks.
So like if they lose their marks, there's always tattoos to go back
That's
to.
right.
But the marks are nicer because it's just so much faster.
Yeah, it is, But again, it's a little more inaccurate because of the thickness of the marks. You could set up on the CT marks because everybody's now using IGRT, or most people are now using IGRT. So you set up on the tattoos, IGRT moves it 3 centimeters. Because that's how far off your treatment is from your CT. Is that a problem?
Is it a problem that you're lined up 3 centimeters off your mark? Is that what you're asking?
Well, I'm asking if you're lining up to what you know is the CT marks, not the treatment marks, and your IGRT or your whatever you're using for IGRT is constantly 3.5 centimeters out. You're moving 3.5 centimeters. The theory is that you shouldn't have to move, for IGRT, you shouldn't have to move more than 1 centimeter.
Yeah.
So that's why it is a problem. If, however, they lose their marks, then yeah, sure, use your tattoos. Do portal images if you wish, or do a cone beam CT once. If you have to shift that amount, then theoretically, you should do another cone beam CT to make sure.
How much radiation do you get for full arc CBCT? So if you mess up and you have to do it again,
Well,
with the whole Alara thing,
yeah, but remember, how much dose are you giving the patient overall?
that's what I'm asking.
No, it's very,
It's like,
yeah, it's very, very little
and most things you do nowadays.
in comparison to the amount of treatment you're giving. It's the same when we have patients who decline to have portal images done every 5 treatments because they don't want any more x-rays. And the doc will look at them and say, you are getting an enormous amount of radiation from your treatment and you're concerned about 1 x-ray a week? Get real, woman,
You know, and I would think 3 centigrade a week would add up towards, once you get to the end of the treatment,
Well,
especially when they're
in
doing more
some-
than 1 CBCT.
In some departments, it used to be that they will take off the dose of the cone beam CT off the treatment. But these days, they've decided that
Negligible.
it's negligible.
It's just kind of a shock for me because like at Gainesville, they pretty much CBCT everybody.
Yeah.
Everybody.
Yeah.
One time.
Yeah.
If possible.
Yeah.
And now where we're at, I mean, we've got patients where they do like
4.
Yeah.
4
I've
CBCTs
had 4.
per fraction.
Yeah.
I'm
Can't
like,
get that bladder right.
Yep.
dang.
Yeah, in Gainesville, they will only do multiples if they like have to.
Yeah.
Okay.
Like,
Well, again, it depends on the individual protocol. If you have a protocol that states, if you have, and this is to your question, if you say the patient loses marks, or, for example, the marks have shifted a little bit, and you find out that your cone beam CT shift is more than acceptable, which is maybe 1.5 centimeters, then the protocol states that once you have positioned it, you have shifted to where you think you're treating it, then you do another one to make sure. Because you've already moved it 1.5 centimeters. So that was outside the protocol.
Some places, like if you do more than 3, you have to just send them home and not treat them for that day. That's all.
That again is protocol, so, yeah. I mean, if you do something like you have a prostate patient and they have a full bladder, supposedly full bladder, and you bring them in and you do a cone beam CT and it's barely there. So you take them out of the room, send them off to sit there for 15 or 20 minutes, maybe take an extra couple of gulps of water, bring them in, say, do you feel as if you need to go pee? And they'll say, yes. So you bring them in and you do yet another CT, cone beam CT. And it's marginal. So do you treat them at that? Or do you do it again? Send them out, bring them back, do yet another CT.
Well, if the doctor approves it.
If the doctor approves that, then that's fine. That is the protocol. I mean, if you call the doctor and say, look, it's barely 50% and you like 75, can you please have a look at it and tell us what you would like to do? And he can come back and say, get them off the table, do another one, and if it's good, go ahead and treat.
I just think that's dumb to send them home after that because, I mean, really, you're just gonna have to add another day to their treatment, which
Exactly.
means another CT. So,
Yeah.
I mean, what's the
Yeah.
difference if you do it now or then?
Yeah, and it, again, it's just what the department protocol happens to be. And it also depends on how, I hate to say this, picky the physicians are. Obviously, they want to do the best for the patients, but if they say it has to be 75% full, and you know it has to be 75% full, and then normally it's 75% full, but there's a problem today, what do? You call them and say, what do we do? What would you like us to do? That's the buck stops here type thing, you know? They have to make the decision, it's a clinical decision. Okay. Yeah. See you next week.